Good evening, everyone. Good evening, Usha and Fairuz and Santosh. After that amazing talk by Santosh, a landmark work, which we all will look forward to for a long, long time, I go on to the subject of thyroid eye disease. Thyroid eye disease, as we know, is an autoimmune inflammatory disorder affecting the orbital tissues with characteristic signs that involve the eye and orbital tissues. We know that the most affected age groups are from 30 to 50 years of age, and females are more likely to develop thyroid-associated orbitopathy. This figure may not be as high in Indian subcontinent as it is in the US or in Caucasians, but still the females are the predominantly affected people. The thyroid status most often is hyperthyroidism, although euthyroid Hashimoto's thyroiditis may also be associated. For the pathogenesis, we know that the TSH receptors and the insulin growth factor receptors, IGF-1R receptors of the orbital fibroblasts are the target of the autoantibodies, which result in various changes, including the enlargement of the extraocular muscles, infiltration by the inflammatory cells, and proliferation of orbital fat, connective tissue, and lacrimal gland tissue, and fibrosis in all these structures. The clinical course is an active inflammatory phase which may last anywhere from 6 months to 18 months, followed by a decreasing activity and an inactive phase. And this is higher than the baseline, which means it leaves behind some effect. And the effect of all interventions is to try and bring this closer to the baseline. And this is the classical Rundle's curve. The ocular symptoms we are familiar with, involving the orbit, muscles, and the tissues of eyelid, conjunctiva, and cornea. The ocular signs are accordingly proptosis, extraocular muscle restriction, eyelid signs, conjunctival corneal signs, and the major risk of optic neuropathy due to compression. So these all need to be in all cases at all the visits and appropriately staged and classified. We must monitor these patients for visual acuity, visual fields, color vision, optic nerve edema at each stage to look for the earliest signs of compressive dysthyroid optic neuropathy. Glaucoma or raised intraocular pressure may also be a factor. Imaging is important in certain cases. Muscle thickening is very characteristic, and we need to differentiate the muscle predominant and the fat predominant disease. Apical crowding is something to look out for the dysthyroid optic neuropathy. The classification, the classical no-specs classification is no longer preferred, and clinical activity score given by Moritz et al. Is very often followed to look for activity. And the classical 7 signs, 1 point is given for each, and a score of 3 or above is considered as active thyroid disease. So this is what we follow for activity, and for the severity into mild, moderate, and severe, the UGOGO classification is usually followed. The disease, when it becomes sight-threatening, is classified as a separate group. So this adds to what you have with regard to activity in regard to the severity and its potential to affect the sight. The management comprises smoking cessation is one very important aspect. Thyroid status is another one, and we look at some of these other aspects more closely. Some of these conservative measures, including lubricants, elevated head, and prevention of exposure keratopathy, are important. There is enough evidence that smoking cessation is very important to prevent the severe form of disease. Corticosteroids remain the mainstay for us until the newer available drugs become less expensive, and IV therapy has been shown to be more effective than oral therapy. They are more particularly used in compressive optic neuropathy and for moderate to severe disease. And there are various options for intravenous therapy. One of the commonly followed regimens is 0.5 milligram, 0.5 gram per week for 6 consecutive weeks, followed by a less robust dosing schedule with a total not to exceed 8 grams. It was shown that if you approach that 8-gram dose, it is more efficacious than using lower dosages of steroids. Orbital irradiation has its own place, particularly in those with severe thyroid eye disease. And we know that optic neuropathy and soft tissue changes respond better than proptosis and extraocular muscle disease. And a dose of 20 gray is often used. There are other regimes which are less dose intensive. Biologics have again a role which is yet to be established, but they're being increasingly used. Rituximab therapy has been used in several series, but without any conclusive results. Teprotumumab has come as an extremely promising therapy with a multicentric study on intravenous therapy every 3 weeks for 24 weeks, showing a good therapeutic response starting within 6 weeks, and nearly 69% of patients showed a response, with a number of parameters showing regression. Decompression is indicated when there is corneal exposure or sight-threatening optic nerve compression, but increasingly we use it for active orbitopathy, especially with congestive change, cases with congestive changes even without activity, and for aesthetic indications. It is important to see whether it is a predominantly fat disease or predominantly extraocular muscle disease in deciding your method of decompression. Fat predominant decompression may be adequate in those where fat predominant disease is present. In others, removal of bone may be necessary. Isolated fat decompression works in approximately causing 0.93 regression per milliliter of fat removed, and it has minimal side effects. In muscle predominant disease, you need to combine the bony decompression, but with increased risk of induced diplopia or other problems. The severer degrees of exophthalmos will require a deep lateral wall decompression as well, but with greater risk. And these are the areas in the lateral wall which are particularly targeted. With even severer disease, you may need to combine it with a medial wall and a floor decompression. And you can have a graded response based on amount of the proptosis that is present. Compressive optic neuropathy, you need to be more focused at treating the apical regions, including the posterior part of the ethmoids and the palatine bone. Because unless you target them, you will not get a decompression of the optic nerve well. For aesthetic goals, you need to customize it well, considering patients' old photographs to see which bones need maximum alteration. The current commonly used approaches are the upper lid crease incision, transconjunctival, including the transcaruncular approach. And these are the approaches which are aesthetically good and provide good results. An example of a transconjunctival decompression, pre-op, post-op, side view on the both the sides. When used for congestive orbitopathy, again, the results can be quite dramatic. For cosmetic indications, you may need to combine a decompression with an surgery for eyelid retraction. You need to follow the order of orbital decompression, followed by motility, and followed by eyelid surgery. And this may be required both for upper and lower lid. Various approaches for thyroid for the lid retraction are present for upper lid and lower lid, and they yield fairly good results with proper selection of cases. But a better understanding of the disease and improvements in medical therapy and improved minimally invasive and customized surgical approaches have led to much more gratifying outcomes in the management of thyroid eye disease.